Hello, good morning friends, and today we'll be discussing about carcinoma prostate. So carcinoma prostate is the most common malignancy in men and especially in the old age group, and it is associated with positive family history and gene involved being BRCA2 more than BRCA1. Uh, Risk factors are obesity and metabolic syndrome to be combined with it, and smoking. These are risk factors, and since these can be modifiable, there's a chemo prevention topic with 5 alpha reductase inhibitors like finasteride, but it is controversial. It is not yet very clear. So what is the pathology? It starts generally in the peripheral zone, the surrounding part, the purple part which is given, and uh, most commonly, which is 60 to 70%, very less commonly 10 to 20% in the transition zone and 5 to 10% in the central zone. Most commonly, these are adenocarcinomas, more than 95%, and 5% are the heterogeneous from the stromal ectopic epithelial tissue. These are multifocal most of the time, mode of spread being influenced by the tumor grade, strongly influenced by the tumor grade, local spread to the seminal vesicles, bladder, neck, and trigone, which is more common. Then we have in it can also occur in the ureter, distal sphincter, rectum rarely due to denonvillous fascia, which is behind that. Then increased grade leads to perineural invasion. Then it leads to lymphatic spread to the iliac nodes, obturator nodes, and retroperitoneal nodes. Hematogenously, it can spread to the bones, osteoblastic lesions. Also, it can spread to liver, lungs, and brain. Other bones involved could be pelvic bones and lower lumbar bones and vertebrae. And it is connected, the prostate is connected by the vertebral plexus, uh, Bateson's vertebral plexus, which is valveless. So most commonly it involves the vertebrae, lumbar vertebrae. So how is the presentation? Presentation most commonly it is in the early stage it is asymptomatic and detected incidentally with help of DRE or increased PSA or during TURP for benign condition, that is BPH. Symptoms could be in the later stages like lower urinary tract symptoms like with bladder outlet obstruction, symptoms of terminal hematuria, and sometimes upper tract obstruction. Due to meds, there could be back pain, bone pain, and neurological deficit, radiculopathy, myelopathy. Examination finding would be prostatomegaly and asymmetrical induration nodularity, that is stony hard features. Lateral sulci, seminal vesicle may be palpable and inguinal nodes may be palpable. Bone and spine tenderness, neurological deficit. For evaluation, we'll have CBC urine analysis for UTI, KFT for the obstructive uropathy features, LFT, ALP for the bony involvement, calcium and chest X-ray, USG transabdominal or transrectal ultrasound or endorectal MRI. Endorectal MRI. MRI will be more specific for the lymph node metastasis, and CT will be more sensitive for the lymph node metastasis. Both will be helpful, MRI and CT, for the local spread. Then PSA, we'll have a detailed discussion on PSA. Biopsy, that will be truss guided biopsy, that is transrectal ultrasound guided biopsy, true cut, and we'll have Gleason score, which will be most commonly used to grade these prostate cancers. So what is Gleason score? It is the sum of two scores, of each score being can vary from 1 to 5. So what is these two scores? first is the score of the most common histology and second is the score of the second most common histology. So the total score will range from 2 to 10, and these 5 grading which each of the score can have, we'll see them in detail. So 1 is small uniform glands, 2 will be more stroma between the glands, 3 will be distinctly infiltrative margins, 4th will be irregular masses of glands, and 5th will be anaplastic and occasional gland. So just to go ahead and understand this in more detail, we'll see the Gleason grading system for prostate cancer in the diagram form. That is small uniform glands, more stroma between gland, infiltrative margins, irregular masses of neoplastic gland, and occasional gland formation. From well differentiated to moderately differentiated to poorly differentiated and anaplasm. So these Gleason grading scoring system will be helpful for histological staging of the aggressiveness of the tumor. And I would like to thank the editors and the speakers of the MAMC 2017 update. Then we'll go ahead with CT and MRI. That will help us in assessing pelvic lymph nodes. Then we have the skeletal imaging, that is the bone scan, especially useful when the PSA is more than 10 nanogram per ml, and PSA is prostate specific antigen and is not prostate specific, but PSA more than 20 nanogram per ml is diagnostic of prostate cancer, and prostate PSA velocity of more than 0.75 nanogram per ml per year is also diagnostic of prostate cancer. We'll see that in more detail in further topic, in further class. So now we'll go ahead with the staging, TNM staging of AGCC. So Tx when tumor cannot be assessed, T0 when the tumor, there is no evidence of tumor, TIS is the prostate intraepithelial neoplasm, T1 when there is normal DRE, less than 5% cancer tissue in the resection for the benign disease, T1b is more than 5% tissue with cancer in the resection for benign disease, T1c when there is detection by needle biopsy after detecting increased PSA, T2 when there is palpable tumor and visible on imaging confined to prostate, T1A when less than half lobe is involved, T2B, T2A less than half lobe is involved, T2B more than half lobe is involved, T2C both lobes involved, T3 is extra prostatic extension not involving other organs, where T3A is unilateral or bilateral involvement, T3B is seminal vesicle involvement, and T4 is the invading of the surrounding other structures. Nodal metastasis is N1 is the regional nodes, which will involve pelvic, hypogastric, obturator, iliac, and sacral nodes, and M1 is the distant metastasis. Grading depending on the Gleason score will be 6, less than equal to 6 is grade 1, so it is grade 1 to grade 5. A minimum is 2 in the grading in the score, Gleason score. Grading is 1 to 5 and Gleason score is 2 to 10. So grade 1 is less than equal to 6, grade 2 is 3 plus 4, that is 7, grade 3 is 4 plus 3, that is most common histology is more aggressive. 4 plus 3, 7, grade 4 is 8 and grade 5 is 9 and 10. Stage grouping incorporates PSA grades along with that. If it is N1, it is 4A and M1, it is 4B. We'll see the stage grouping also in detail. So how is the management? First, we'll go for the risk stratification. For clinically localized disease, that is low risk when the PSA is less than 10, Gleason's less than 6, less than equal to 6, and T1 or T2A. Intermediate PSA 10 to 20, Gleason's 7, and tumor is T2B. When high risk group is PSA more than 20, Gleason 8 to 10, and tumor is 2C or 3A. We'll also look for the table and nomograms. So how we'll go for the treatment of the localized disease? Active surveillance These are especially for the early and low to intermediate risk prostate cancer in men with less than 10 years life expectancy. Matlab, the people who will be expected to not live more than 10 years, for them we don't go for any active intervention, we'll go for just surveillance with help of serial DRE, PSA and follow-up of trust guided biopsy. That is, in especially for the clinical subclinical progressive cases, we have to intervene, but generally these are very slow growing tumors, so we'll go for active surveillance. Then we go ahead with the radical prostatectomy. Radical prostatectomy, now it is commonly done with help of robotic assisted radical prostatectomy. Otherwise, it can be laparoscopic or open in patients with life expectancy more than 10 years with resectable and clinically localized prostate cancer. It's localized to the upper part. Then we have the division. How we'll go for the surgery: complete removal of the prostate, seminal vesicle and ampulla of the vas deferens, division of the bladder neck to remove the specimen, then reanastomosis of vesico-ureteral junction to take care not to injure the neurovascular bundle supplying the cavernosal erectile tissue. That is the nerve sparing approach of the radical prostatectomy. Then along with that, we'll go for bilateral pelvic lymph node dissection of removal of the obturator iliac and sacral lymph nodes. Then we may go ahead with radiotherapy, which can be even primary sometimes and sometimes adjuvant, along with adjuvant androgen deprivation therapy with or without docetaxel. In radiotherapy, we can go ahead with EBRT or brachytherapy. Radiotherapy is commonly used for patients with high risk and decreased life expectancy with poor surgical risk. How we'll go ahead with the advanced disease? Surgery TURP for bladder outlet obstruction, orchidectomy as method for androgen deprivation therapy who are non-compliant and require emergency blockade of cord compression. This orchidectomy is bilateral and simple. Androgen deprivation therapy with help of GnRH agonists, leuprolide, glucoserelin and triptorelin. Adverse effect being flare phenomena. GnRH agonists like degarelix, anti-androgens like flutamide and bicalutamide, enzalutamide, progestins. Then progesterone like megastrol and acetate. Abiraterone blocks the tumor androgen synthesis. It is a CYP17 lyase inhibitor. Others like corticosteroids and ketoconazole. For bony metastasis, we have zoledronate, denosumab, and radiopharmaceuticals like strontium 89 and radon 223. Then we have cytotoxic chemotherapy for palliation, that is mitoxantrone, docetaxel, and capixetexel. Vaccine therapy is for castration resistant CA prostate without visceral mets, that is sipuleucel T. And then we have radiotherapy for cord compression for isolated bony mets, pain not responding to the androgen deprivation therapy, for pelvic pain syndrome, gross hematuria, retroperitoneal nodes causing back pain, edema in scrotum and limbs. So this was all about prostate cancer in short. So keep studying, keep growing, and if you have any concerns, we can discuss. And I would like to thank Chandana Sri ma'am for sharing her wonderful notes, which is helping us understand it in an easier way. And keep learning, keep growing. We'll see you in the next video. Please like, share and subscribe. And thank you for watching.